So, hello everyone. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. My name is Autumn Sipis. I am the project coordinator with the Canadian Coalition for Green Healthcare. And on behalf of the Coalition, Peach Health Ontario, and Cascades, I would like to welcome you to our webinar today, Preparing for Climate Change at Healthcare Facilities, Air Quality, and Smoke Management. This is the second in a 3-installment webinar series from Cascades, Peach, and the Coalition. So thank you again for all of you for being here today. Throughout the webinar, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of our webinar today. We will also be recording this webinar, which will be sent out to all registrants and will be available on our website and YouTube channel at a later time. I will now hand things off to Linda Varengu to introduce today's topic and speakers. Linda is the Senior Advisor of Climate Change with the Coalition, Executive Committee Program Advisor for Cascades, and the Climate Lead with Peach. Take it away, Linda.
Thanks so much, Autumn. And thanks everyone for joining us. As Autumn mentioned, this is the second in our series on preparing healthcare facilities for climate change. Our last one was on wildfires and really well presented by our friends at Interior Health. This one will deal with the smoke, the health effects and impacts on healthcare facilities and how to manage it. And we have a third one coming up on July 25th on heat, which we could all really learn from as well. Oh my God, the things that are happening in our society now are just, we need to protect ourselves and our workforces and our people, and we need to get ready for the things that are coming. So we have two excellent superstars presenting today. First, to speak about the health impacts of smoke is Dr. Courtney Howard. We had a great bio from her in the notice that went out, and I'm hoping that you all read it. She is a superstar in this area, a huge advocate on working on climate change and doing everything she can to green healthcare and for planetary health. And our second speaker is Abdel Darwhich. He's from a consulting company in the United States. Abdel, you'll have to tell the team what it is, but it's all in his bio. And Abdel has been working a lot with the standards organizations in the US, creating appropriate standards to deal with smoke management, and we'll learn a lot from him in the upcoming presentations. So in order to give our speakers the most amount of time, Courtney, why don't you get started?
Sounds good. And I just have to say that I just tweeted out, we have hospital ventilation guru Abdel Darwhich here. So we've got lots of doctors around and we all know what the problem is, but we don't actually have that many people who know how to fix the problem. So I'm particularly excited to be here today and will be taking a lot of notes because we're not taught about different types of ventilation at medical school, and it turns out we need to know that. So very excited to be here. So I live and work in Yellowknives Dene territory, the traditional home of the Yellowknives Dene, the North Slave Métis, and the Welliday Dene. I've lived here for 12 years. I first learned about the climate emergency in Inuvik as a new doctor. And it turns out that when you read the words, climate change is the greatest health threat of the 21st century in the Lancet, when you're sitting in a hospital that sits atop permafrost, that diagnosis lands really quickly. So I've been doing this work for about 15 years. And in that time, the planet has really changed. So they were saying it was an emergency back then, and now it, of course, feels like emergency. It's even hot up here in Yellowknife today, and I know that a lot of Canada is sweltering under a heat dome. And we know that, the heat sometimes does lead to wildfires. So it's a good time for us to be talking about this. I receive honoraria from a lot of smart people like Cascades and other universities. I, however, still mostly make my living as an emergency medicine doctor because it's quite difficult to get paid here to do this work at this point, which is actually something we need to change. As we mainstream this, we need people to be able to be paid at their universities and at their institutions to do this work, because really, right now, we're asking people to change the world off the side of their desks, and we're just not going to be able to scale as quickly as we need to. So what happened? I was, in fact, giving a keynote on wildfires at the Canadian Medical Association Health Summit last year as my hospital was actively being evacuated due to wildfires. And to the point that a senior leader of the military was called away in the middle of my presentation to talk about the evacuation of Yellowknife Hospital. So this is super real. Over 70% of our territory was evacuated. Several communities actually evacuated a couple of times. So Hay River evacuated, went back, and evacuated again. I was coming back from Oxford, where I'd been for the year with my family. My husband found out that the city was being evacuated when he landed in Calgary. And so then we lived as evacuees for about 3 weeks. And we are amongst the most privileged evacuees who could possibly exist. But still, I got to tell you, that's stressful. All of those uncertainties, where are we going to go? Can we find a different house to live in for a few days? It's difficult, even when you have a 2-doctor income and a large social network that's willing to offer you places. So many of my patients, certainly when we came home, almost every presentation in the emergency department when I got back had something to do with the evacuation. There was a lady who, her cast hadn't gotten changed when it was supposed to because she was out of town and there was no fracture clinic available. So it was completely itchy. So many people with chronic obstructive pulmonary disease or asthma exacerbated from the wildfire smoke. So this is already an issue of complete clinical importance. We know from curriculum surveys that doctors are still not getting taught about it to the degree that they ought to be. And I hear from my colleagues in nursing, pharmacy, and others that the same is true there. So this is at the cutting edge, but at the cutting edge in terms of us needing, we're playing catch up at this point with where we need to be. So this is information that you need. A couple of images from last summer, you see that heat across Canada. This is what I've been carrying around. Abdel's going to laugh at me, my current approach. So basically, when I want to know what the PM 2.5 is, I just stick my Dyson air filter in that place. This is my highly technical approach. So this is PM 2.5 of 598 from my deck, which was a terrible day. And you can imagine you're trying to even just keep your house at a reasonable level. It's hard. We had 4 different air filtration devices going inside here, and we weren't keeping up. A lot of the time inside, it was about 70 or so, and we have a reasonably well-made house. When we did a study into smoke after the 2014 wildfires, which lasted 2.5 months, and we'll talk about them later, we did that with the Yellowknives Dene and the Kagatu First Nation. And as we were going over the final draft with the chief of the Yellowknives Dene, he said, look, can we please put something about housing in here? Because of course, we know that Indigenous communities across this land that we now call Canada tend not to have great housing. So when the smoke is happening and rising outside, basically, if you've got crappy housing, it's just leaking inside too. So you're starting to not have any type of a cleaner air shelter that you can go to protect yourself during these long periods. So we're at a period of drought across Canada, now heat. So I think we can anticipate further smoke. In 2014, so here in Yellowknife, we're in the high subarctic. So the tree line's only a few hundred kilometers north of us. We're quite far north. We're warming at about triple the global rate. And so it's not surprising that we're seeing some of, in this case, when we did the literature review, really there wasn't a longer, more intense smoke exposure in the global literature base when we looked. And so we, over the course of 2.5 months, had a full doubling of emergency department visits for asthma. We had a 50% increase in pneumonia. And we did community-based interviews with people from Yellowknife in Kakisa with the Kagatu First Nation and in Dilo with the Yellowknives Dene. and asked people what it felt like to live through 2.5 months, essentially an entire summer of smoke. And they said that they felt disconnected from the land, unable to do regular land-based gathering activities, berries, fish, etc. People really felt cabin fever because they were essentially trapped inside their homes with the windows shut and the doors closed as we're supposed to be. And I'll tell you, in the subarctic, we don't have air conditioning. However, our houses are built to absorb maximum solar gain because that's the way we've usually done it, just with natural ventilation. So I can tell you there are some marital discord moments when we are now trying to keep the windows closed. My daughter has asthma, and my husband doesn't like heat. And so trying to balance the different physical needs of your family members, just even in a normal, just sort of Joe Schmo type family, in infrastructure that wasn't built for current circumstances, it's, that low level challenging. And we, of course, have tons of resources. We're talking about trying to put a heat pump sort of to suck hot air out of our house and warm up water, but that's a multi-$1,000 expense. So think about the elders down the road who just don't have those types of resources. Everybody across the north is starting to deal with this concurrent heat and smoke problem, which happens at much lower temperatures than you would expect just because of the way our infrastructure is built. Many people express feelings of ecological grief or eco-anxiety, saying things like, if it's this bad now, what does this mean for our kids? And the thing I like the best, and which is one of the reasons why I'm excited about this webinar, is that the people who prepared the most felt the best. They looked proud in their interviews. They were telling us, yes, we lined up all of the boats next to the river to provide an alternative means of escape in case the highway was closed. We fire smarted our home and helped our neighbors. We were volunteer firefighters. They stood up straight. They looked straight into the camera. And so what we took from that is that preparation not only practically does good, but it feels good too. And that makes sense. If you don't know what the plan is, even for a child's birthday party, you're going to be pretty stressed out during that birthday party and the times before. So same's with wildfire emergencies. This is not something we want to sort of push under the rug and not think about. This is something we want to really consider, plan for, train for, and be ready for. Just saying that sometimes doing this kind of thing requires unconventional partnerships. So this is James Urbinski in my kitchen. He is really my ultimate hero, the person I wanted to be when I was a medical student. He accepted the Nobel Peace Prize on behalf of Doctors Without Borders for his work there. And I pitched to him this project without premeditation the first time I met him. And so sometimes in order to get things done, you need to make asks of people in a way that's kind of scary, but sometimes they work out. So if you're in a position where you have a change project at your institution, whatever it is, if it's related to smoke or heat or decarbonization, don't be afraid to ask people who seem kind of powerful for help, because sometimes they want to help, but they don't know how to, and you're actually offering them a pathway. This is what our PM 2.5 graph looked in that summer of smoke in 2014. So PM 2.5, it's anything that can fit through a grid of less than 2.5 microns. So it doesn't discriminate based on what it is. It's a complex mixture of toxic substances, and it depends on what is burning, what's actually in there. The toxicology isn't precise enough yet, really, for us to be able to say there's, to expect this basket of respiratory problems if it's more man-made materials versus forest that's burning. But we kind of are getting the sense that probably if it's man-made materials burning, it's a little more toxic, but the literature to this point isn't sensitive enough to discriminate. So the purple sort of pinky line there is the NWT reference average at the time, so 30 or 28. We were trying to keep PM 2.5 under 28. That's still about what we would like to see PM 2.5 stay below indoors. So when Abdel comes and talks to us about all the different ways we can keep our air clean, I just wrote a paper with Sarah Henderson from the BC Centre of Disease Control, and she's involved in helping to set some of the guidelines that Abdel will be talking about. And so in the next set of guidelines that are coming out, what they've come to is trying to keep indoor air quality below 30 if possible. It's been interesting in conversations with her and in conversations with Health Canada, the people who are in charge of this nationally. there was a sense that those groups would like to see basically it was the minimum achievable concentration of smoke inside. And I can understand how that makes sense from an engineering standpoint, but that doesn't really make sense from a patient-centered clinical standpoint. I think we need to set targets at what we can look a person in the eye and say, look, I think you're reasonably safe in my emergency department if we get it below 30. What they were suggesting was an 80% relative reduction in outside air quality. But at that point, half the time you might be ending up trying to get all of your patients and staff to wear an N95 inside if you haven't managed to hit a level that's actually safe. So I think we need to set our level at what's actually safe and then just work to achieve it. And if we haven't achieved it yet, well, fine, we'll change next time or we'll build our hospitals differently. But we need to, I believe, take a patient-centered approach to this. So what do you see when smoke gets bad? So if it's just a little bit bad, people will start to complain about itchy, watery eyes. Then they'll start to get a little bit more short of breath. This is sort of the bottom part of that pyramid there. Then they'll start to get to the point where they may need medication use. A couple of days into a smoky episode, we often get people coming in for puffers who are coughing. They'll often say, I didn't used to need puffers, except for when I was a kid. When I was a kid, I used to sometimes use puffers when I had an upper respiratory tract infection. So we tend to see the same cohort of people who needed a little bit of bronchodilators when they were a kid during cold and flu season, being the people often who will come in requesting a puffer during smoky season. So it's sort of people a little bit more predisposed to bronchospasm that tend to come in. And then we start to have them being bad enough that they get admitted to hospital. Now, a couple of years ago, really, there wasn't a lot of consensus in the literature that this extended beyond respiratory problems, but now there is consensus that we're starting to see quite a lot in the way of cardiovascular outcomes as well. So if people come in with saying, you know, my chest feels heavy, don't just attribute that to asthma. You need to do a troponin, you need to do an EKG, because they are at increased risk of heart attack and different types of cardiovascular outcomes. And this has to do with the fact that those ultrafine smoke particles get all the way down into your lungs, cross over into your bloodstream, and lead to an inflammatory cascade. So we know that once we've triggered an inflammatory cascade within our body, we start to get symptoms and clinical problems far, far, far from the site of our lungs. And we need to be really broadening our diagnosis during those times in recognition of that. So you can see they're really saying increased potential cardiac arrest as well as increased mortality are things that we're seeing as a result of the effect of this on our heart. Now, again, it was only 2022 when we got this study that actually shows we're probably also at increased risk of lung and brain cancer as well long-term. So when you think about the fact that this study was a longitudinal study of more than 2 million Canadians followed for 20 years, and it still found an effect comparing places that had been exposed to wildfire smoke with places that hadn't been exposed, and think about what those exposures were. Looking back 20 years, they weren't nearly as bad as the exposures are going to be looking forward 20 years. So when people ask me, you know, do I need to worry about this study? I say, yeah, you know, this is why I work so hard to try to keep the air quality inside my house good. It's why I keep my kids inside. And it's why when we go outside, we wear an N95 mask, because I think that we're going to see that cancer rates are likely to be affected by our smoky summers. And we need to be protecting against that before all of the evidence is in. So the AQHI, which is produced by Health Canada, is a really, really great tool. Every physician, every clinician really should know how to use it. It's not something, again, that we're taught in medical school. It's starting to be taught. And what you need to know is you need to know where to go in the Air Canada website and how to counsel patients. So if people are part of the general population, there's one set of guidelines for them. If they're an at-risk population, so that tends to be babies, pregnant ladies, people who are elderly, people with pre-existing conditions like chronic obstructive pulmonary disease, and people who work outdoors. So they should be doing less at a given level of air quality reduction than people who have less pre-existing vulnerabilities. But remember, there's no safe threshold of exposure to PM 2.5. Some studies done on large populations have shown impacts with very small exposures. So we should all be minimizing our exposure. N95s are your friend. We have a stack of these next to our door, and we often pick one up when we leave the house, whether it's to protect against COVID, which again is surging in many provinces right now. So not a bad idea to be wearing one of these if you're out and about, as well as due to wildfires. We order them from Masks for Canada for our children. You can get blue ones and purple ones that are KN95s. Our kids like those a lot better. So I would advise you to have some of these well fitted to every member of your family and to know where to advise patients to go get them. Now, this is where we're coming to. This is starting to be a transition into Abdel. So we don't have indoor air monitors in our emergency department. I was getting texts from all of the nurses last summer saying, hey, Courtney, I have a headache every single time I go to work. And this is where the type of facility that you have really starts to matter. We have a new hospital, but it was built by a company that usually builds prisons in Texas. As I was telling people before the call, it is extremely difficult for us to change anything to do with the infrastructure. When our emerge doc office door doesn't close, an alarm sounds, and we've been trying to get that changed for 5 years, and it's been very difficult. And so this is at the place, changing these types of things depends on the relationships you've got, depends on the structures of the hospital. But Abdel will be able to tell us what we actually need to know. This particular day, I got so frustrated because I could smell smoke that I actually asked my husband to bring our air quality monitor, which is on the air filtration device, into the hospital. So he did. So you can see the PM 2.5 there is 18, which isn't bad, except for the fact that by the time we did that, it was 9 outside. So we were actually concentrating smoke in the emergency department compared to what was happening outside. And, you know, most of our hospitals were not built anticipating this type of a smoke burden, and many of them are having to close their operating rooms because they're still entraining air from the outdoors. And we need to anticipate the fact that these are not one-off seasons. It is going to predictably get worse until at least mid-century under all feasible emissions projections. And so we need to prepare. Again, this is Canada's emissions trajectory, this is our temperature trajectory. We're on the red line right now. So if we decrease greenhouse gas emissions emergently, we will hopefully get to be on the blue line. But regardless, from this point to the mid-century, we're going to keep warming. So we need to get ready. And this has really critical consequences for our kids. So as we are moving towards implementing the Declaration on Planetary Health at all medical schools, I anticipate a lot of uptake across Canada and real change over the next couple of years with the work that Cascades is doing. We're going to start to see more of a push, and we need to know what to look for our current patients and our patients to come. And so I'm very excited to end there and listen to Abdel.
Thanks so much, Courtney. That was an excellent presentation. Things that we probably don't want to hear, but we need to hear. And it's the reason why we also need Abdel on this call and his presentation to help us figure out how to manage the smoke that we do encounter at the healthcare facilities. So Abdel, would you like to start your presentation?
Yes, my pleasure. Thanks, Courtney. Presentation. I'm gonna start sharing my screen. Can everyone see my screen?
Yes, it's great.
Okay. Yeah, perfect. So again, I want to follow up on Courtney's presentation and really dig a little bit deeper into the engineering, the technical aspect. I promise I won't be as engineering technical as I can. So the question is, I mean, why are we talking about wildfire and why specifically for hospitals? I mean, wildfires is not new for Canada. It's been happening for the year, but the magnitude and the intensity and the duration have been increasing tremendously in the last year. 2023 was one of the worst seasons in Canada. This actually is, I have a personal connection, if you want to call it a personal connection, with wildfire smoke. I live in Sacramento, California, and these are pictures just 5 minutes away from my house. This is downtown Sacramento. This is 2018. This is the first year that we really felt wildfire smoke is impacting our life. You can see what happened in October, just 1 month's difference. And during that month, I think 9 of the 10 most polluted city in the world were actually in California. And again, we didn't have wildfire in Sacramento, but it was the wind who was blowing it. The company I work with, actually, the main office is in San Francisco. It's about 2-hour drive from Sacramento. And this is what happened in September 2020. I mean, you can, and this is not filter picture. This is actually was like this. It was really scary. And again, there was no wildfire in the city, but the interaction of the wildfire with the sunlight in the high atmosphere created this orange looking. And this is the Bay Bridge. It's not the Golden Gate Bridge, but it's another bridge that's famous in Sacramento. And wildfire are also reaching, I mean, areas that you didn't expect it to reach. I mean, can you imagine? This is Hawaii, this is Lahaina and Maui. And 2023, they even had a wildfire. And again, why hospitals? Because, I mean, hospitals are among the buildings. It's not easy to evacuate in a wildfire or in any emergency. And they house one of the most sensitive population, people with lung disease. So quickly, my presentation today, I'm going to start with some background information that will help us set the stage I mean, I'm going to use a lot of terms, so I said it's better to talk about them. And then I'm going to talk about some sensing, which Courtney covered, the importance of using sensors, and then the planning. And then I'm going to mention 2 key concepts about how to protect any building, especially hospital, from wildfire smoke, and how we go about them. And the last slide, I will keep it a surprise, something I call triple Murphy law. And once I get there, I'm sure people will laugh when I say it. I mean, laugh in a maybe a good or bad way, but it happened. So what is really wildfire composed of? And it's not an easy question to ask. I mean, wildfire composition varies a lot based on the fuel burn, the moisture content, the fire temperature, the wind condition, you name it. So it's not easy, but what we really know is that wildfire is made of 2 big buckets. One is the gases, and second is the particles. So the gases, we have the NOx and we have the VOCs. So the VOCs, the interesting is that they are the most smellable. So when you smell wildfire, that ashes, that's smoky smell, that's actually the VOCs. And there is also some ozone, which is usually a result of the interaction of NOx and the VOCs with the UV. Now, in the second bucket, we have the particles, and particles are mostly, carbon and heavy metal. They usually are very in sizes, but as Courtney mentioned, the most dangerous is the PM 2.5, and they are dangerous because they can penetrate deep into the human lungs. So again, I want you to look at the difference. So the most dangerous component of wildfire is not the most smellable. So sometimes you could filter PM 2.5, you may still smell fire, but it's not the most dangerous. And this will be important in the filter that we select. So what happened during the wildfire? And I want you to start, we're going to start from the bottom. You can see ozone, you can see what we call the SO2 and the NOx. So there is some increase in their concentration over, so between the 2 red line is when a fire happened. There is some increase, but it's not much. I mean, maybe SO2 increased by 2 to 3 times. But really, the biggest increase is in PM 2.5, and you've seen Courtney sensor. I mean, on her balcony. So PM 2.5. I mean, in a wildfire, could shoot as 10 times. It can go from 25, 30 to 300, or even more, which is really is like what we call a double whammy, because it's the most dangerous component, and it's the one that increased the most during a wildfire. So also another background information about filters. So we have 2 types really of filter. There is particle filters, and these usually are like the one that you have in your houses. They basically are, there is a mesh, and the mesh is made so small that particle cannot pass to it. So they basically stop the particle. Typically, they cannot stop gases. Gases particles are so small that they can get through the mesh. The gas filter, though, is a different. So do we have the physical and we have the chemical? So the physical is what they do is that you put some material like carbon that will absorb the gas, the contaminant gas. So it doesn't change the gas, it just absorbs it. And there's another type of filter, which we call the chemical gas filter. This actually introduces a new material that interact with the gas, and it change its chemistry. Another background is what ASHRAE, which stands for the American Society of Heating, Refrigeration, and Air Conditioning Engineer. A few years back, it started working on a guideline, which is Guideline 44. So the title is a mouthful. It's protecting building occupants from smoke during wildfire and cascade burn events. I had the honor to serve on this committee. I'm a voting member of that committee. So we started in July 2021. And because the wildfire is such an important topic in Canada, actually half of the committee is actually from Canada. We went out for first public review. We got about 80 comments, which is really not bad for a first publication public review. And now we are actually, so we addressed all the comments, and now we are in the second public review, and we're hoping actually to publish this guideline by the end of this year. So that's the background information. So well, first, you can't do anything if you don't know. So this is why it's very important to know. And this is why in Guideline 44, we recommend the installation of PM 2.5 sensors. And we recommend you install those outside in your building, or if you can link to basically an adjacent weather station to get this, you can do that. An entryway, for example, in the ER department, in ambulance bay, in hospital, in loading docks, any areas where you have frequent opening of doors, we recommend to add, and in high occupancy area or areas occupied by at-risk population. At-risk population are people maybe that have lung diseases. And again, this will tell you how PM 2.5 is getting to your building. In addition, we also recommend to add building pressure sensor. So what building pressure sensor will tell you is that if your building is positive, and I will come to that, it's very important to keep your building positive to prevent wildfire smoke from getting in. The second is that you have to plan. So every facility, especially hospital, need to develop a smoke readiness plan. And Guideline 44 actually there's like 6 pages of how to develop this plan. Usually it have 4 sections: the preparation, the what and the who, who's doing what, and what we need to do in case of smoke. The testing, so after everything is set, you need to test it before actually wildfire smoke. Then the implementation. So how do you trigger the smoke readiness plan? Is it automatic based on sensing PM 2.5, or is it manual where people will say, well, we have wildfire smoke, it didn't teach us, but it will. So again, there are various options, but it needs to be in the smoke readiness plan. And last is basically how you return to normal operation. Do you need to flush the building to get the smell and the VOC and the PM 2.5 out, or do we just go back? So again, you need to cover this. I will not go into the details. I mean, Guideline 44 have like 6 pages of this. So that's coming. The most important thing is that the smoke readiness plan need to be coordinated with the infection control group to make sure, especially in hospital, to make sure that if you are, for example, playing with certain pressure in certain room, that you're not actually increasing the risk of infection. Most importantly is that if you have a smoke readiness plan developed, it shouldn't sit on the shelf. It should be made well known, especially for the O&M people, the operation and maintenance people, to know what to do. If it's a new project, usually when we start a new project, we develop a document called the owner project requirement and the basis of design. So the owner have to come and tell the design team, if they're designing a new project, well, I want my building to continue operating in a wildfire smoke, and this is my smoke readiness plan. Please design the building accordingly. And many times now, actually, when I design new project in what we call the sequence of operation of the HVAC system, now we have smoke mode. So in case of smoke, how the HVAC system is supposed to operate. So let's now get to the 2 main concepts, how you protect a building or a hospital from wildfire. One is to prevent the smoke from getting indoors. That's the first concept. The second is, well, eventually some smoke will get in. So what do you do about this? So these are the 2 key concepts for protecting a building. And I'm going to go into the detail of each. So let's first get the first concept, which is you need to prevent it from coming in, the wildfire smoke. So how does actually wildfire smoke get into a hospital or a building? First, the intake, the outdoor air intake at your HVAC system. 2 is the doors, the envelope element, the window, the skylight, and other penetration in the opaque envelope. Leakage, actually, through the walls, and people don't know it, but it could be leakage in the walls that you don't see. And if your building is negative, well, here you go, you're sucking smoke in. Last is the emission from contaminated clothing from occupant. This usually happen in the ED department or other areas. And usually HVAC, the HVAC system cannot do much into this last point, so I will not go over it in details. So let's first with the first one, outdoor air intake. These are, every HVAC unit usually have an outside air intake, and usually is a source of wildfire smoke entry into the building. So the mitigation is you need to minimize outside air, but don't completely shut outside air. I've seen some people shut outside air. The problem is that if you completely shut outside air, which is used to dilute the indoor contaminant, your indoor contaminant, from people, from the walls, from everything, will shoot up. And you may get to a situation which is actually maybe, again, it's possible to get to some contaminant may reach unhealthy conditions. So don't do that. Disable economizer. So economizer, we use them sometimes when the outside conditions are cool enough. So you use 100% outside air. So you're not recirculating the air. And whenever there is a wildfire smoke, it's not a good time to save energy. So we usually ask to disable economizers. You have to seal any ducts. If you have any ducts on the roof that's under negative pressure, that duct will suck wildfire smoke in. If you have a natural ventilation space, well, that's not the good time to naturally ventilate it. So usually we ask people to switch to mechanical ventilation if there is ventilated space. The second way for wildfire smoke to enter is through door and entrances. And usually we recommend to have positively pressurized vestibules at all entrances. So there is no direct communication between the hospital and the outside. If you cannot do that, you can add curtains. Air curtains are all frequently used doors like the ED, the emergency department, and the loading docks. And again, those air curtains are just, they bring air in. So it's like a curtain of air. So basically when the door opens, wildfire smoke cannot get in. If it's a new building and you have an architect that's, I guess, open to working with you, you can design the building to avoid main door facing the prevailing wind direction. So you have always the main door to be actually downwind. The envelope. So again, the envelope is a way for wildfire smoke to get in. You need to weatherize the building. Make sure that it's airtight. And if an existing building, usually I recommend you do a visual inspection, which is usually just you walk in, you see daylight. Yeah, that's a cap. You can also take it to the next level, do a physical inspection, which is sometimes it's like you pressurize the building with fans and see does the building hold the pressure. It's like, checking the pressure in your tire. You pressurize it, put it in a water, see if there is bubbles. That's basically what you're doing. People, you can also take it to the next level, which is what we call infrared imaging, and you can see it here on the right. There is you can see there is a construction wall here on the bottom right, and you will think, oh yeah, that's basically sealed. But then when you look at it in an infrared camera and increase the pressure in the building from 0 Pascal to about 60 Pascal, you can see it's getting darker and darker and darker in blue, which means that there is air passing. So that's a leak that you have to address. If it's a new building, usually we ask for you to commission the envelope. So make sure that the envelope is tested before the new building is delivered to the client. And really the key measure, so the key takeaway to avoid having smoke get in is to keep your building positive. And again, it's simple, physics. Once you bring out more outside air than what you exhaust, your building will be positive. You can use your building management system and install airflow measuring stations so you can measure the flow in of air and measure this out and make sure that the air actually in is more than the air out. Now we get to filtering of wildfire smoke. And again, as I mentioned, the most important goal is to filter PM 2.5. Optional, if you want to go to next level, you can filter the gases because PM 2.5 are the most dangerous. The question is always, so what filter efficiency is needed? And in our guideline 44, we gave two methods. One is the calculation method, and number two is the minimum MERV method. The calculation method, again, don't get scared by this equation. We developed this equation from a mass balance. So if you know your outdoor PM 2.5, your indoor PM 2.5, and your filter removal efficiency, you can plug it in, play with this. You can say, well, I have a certain leakage rate. What will be my filter? And again, if you don't want to do this advanced math, filters are usually rated on a MERV. That's what basically actually 55 is, which is the minimum efficiency reporting value. So guideline 44 recommend a minimum of MERV 13, and MERV 13 actually stops about 85% of the PM 2.5 passing through. And again, it doesn't mean that 15% will get to the building, but again, keep in mind that you have some circulation. So as the air passes over the filter over and over and over, it will remove more than that. And most hospitals should have this. So really, MERV 13 should be achievable in any hospital. Some other filter consideration is that you need to change the filter very frequently during a wildfire smoke, because it will get dirty very, very, very quick. In ASHRAE Guideline 44, we give a method of how you can estimate this. I will not go over it now for lack of time, but irrespective, you have to basically anticipate to change the filter very frequently. I mean, I've seen some hospital changing filters down as frequently as 2-3 days, but they were in very bad wildfire smoke situations. A lot of them change it every 1 or 2 weeks. I mean, versus normally you would change them every 3 to 6 months. More importantly is, instead of you may think, well, I want a better filter. Well, before you do that, inspect your filter frame. I mean, not you. I mean, then people should inspect the frame for any leakage. Because I mean, leakage around the filter could be really a problem. I mean, you could install a MERV 13 filter, a very high efficiency filter, but because you have leakage around the filter, actually that filter is downgraded to nothing. If you want to go minimum, if you want actually to go beyond the minimum, what we are doing now, some of the project that I am designing, we actually in an AHU, which is what we call the air handling unit, the central AC unit in the hospital, we just leave empty racks to put what we call HEPA, which is really the high level filtration. It's actually even higher than MERV. It will stop the unit down to PM1 even. And gas filters. So because these are high pressure drop, they consume energy. We don't usually put them there if you don't have wildfire smoke, but we have the racks ready, and we have actually the fan are strong enough to handle this in the future. So we have the racks ready, and part of your smoke readiness plan will be for your operation and maintenance people to go and slip those filters. They have to have them ready if you have wildfire smoke. Keep in mind that you obviously extra filtration means extra energy usage. Now, assuming that you can't do that in a central system, and you have to use, sometimes you end up having to use portable air cleaner. I've seen it used in some hospital. Important thing is that they have to be purchased in advance and stored, because once there's wildfire smoke, it's very difficult to find those. They go out of stock easily. Make sure that they actually don't make things worse by generating ozone. Ozone is another contaminant that's bad. One of the challenges is that these portable air cleaners are still in USA and in Canada actually regulated in a residential way by AHAM, and using what they call the CADR, the clean air delivery rate. And for wildfire smoke, AHAM recommend basically one CADR for 1 square foot of room. So if you have like a 120 square foot, that's about 12 square meter. Or less, maybe 11 square meter. That's roughly the exam room in a hospital. So you need to select a portable air cleaner that have a CADR of 20. More important thing, actually, some owner now are asking us for more power outlet and storage space. So you need to have storage to store those things, and more power outlet in patient rooms and in the corridors and everywhere, so you can plug those. So that's actually for if you are designing a new building. And moving now, I mean, I've talked a lot about HVAC filters, but during wildfire smoke, I actually got some interesting feedback from some of the hospital owners here. And it wasn't only the HVAC filter that are loading, So that you have your compressed air. So compressed air is one of the medical gases that you use in hospitals. Usually this is generated by an air compressor somewhere in your mechanical room. And that actually air compressor suck air from the outside through a filter. So what they were noticing is that filter was clogging very, very, very quickly, basically, and some actually hospital lost their medical air. So now we do recommend actually, for example, for that filter to have 2 in parallel. So in case one's clogged, you can switch to the other. And we ask actually hospital owner to keep an inventory of those filters, so they have so many on stock, so you can change them frequently. The other one that some hospital owner were reporting is the NICU, the NICU incubators. So the NICU incubator, you can see them here. They have also a filter on them, some of them at least. And a lot of hospital owners were reporting that these air filters, whenever there is wildfire smoke, were also being plugged very quickly. Irrespective if you have actually filtered the house air from the HVAC. And, you know, those, I mean, I'm not a doctor, but I know that, newborn, babies in NICU are one of the most sensitive. Their lung is not developed. So this was creating a problem. And the thing is that the hospital didn't have enough filters actually for those NICU incubators. So it's very good to have inventory in your hospital for all the filters, not only HVAC. Every filter that you can have, you need to have spare parts, and you need to be ready to change them very, very frequently. Which now brings me to my last slide, which is what I call the tripping law. So if somebody actually asked me, like, 5 years ago, or I live in California, so if I want you to design a building that will at the same time be able to withstand an earthquake, a pandemic, and the wildfire, I probably will laugh at them. I would like, well, you know what? That's sure. It's very difficult. This is very improbable to design for. But you know what? So we live in California, so earthquake is an emergency that we always prepare for. I mean, we have a lot of requirement in our code for earthquakes, especially for hospitals, because they need to operate after an earthquake. So we have a lot of those requirements. But then in 2020, COVID hit. And in the fall of, in I would say August, September, and November, we had wildfire. So really, we had wildfire and the pandemic, and we had multiple earthquakes happen in California at the same time. So I was, getting some phone calls that like, what do I do? I mean, pandemic, should I go to 100% outside air? But wildfire tells me I need to minimize outside air. And even if I find a filter, I mean, if we ask you to go to 100% outside air, can I find a filter that will withstand the earthquake? Because, we have a requirement for, for everything that you choose, any equipment you choose in a hospital need to be operation excellent. And there was none. Well, that was actually before now. I mean, some of you know there is a new, basically, actually standard 241, which is the infection control in all buildings. Now, this actually standard tells you that you actually don't need to go to 100% outside air in a pandemic. There are some calculations. You get a certain airflow, but it's not 100%, which is good. So now if people are asking what do we do in pandemic and wildfire, go to the actually 241 airflow and actually, filter them as much as you can. That's the end of my presentation, which I think leave us about 12 minutes for question and answers.
Thank you. My goodness. Yeah, you're getting applauses. This is just incredible information for facilities people, especially, but for anybody who's on this call to take it back to your facilities people. We will have a recording of the presentations as well as the slides, and we will be able to share this with the participants and those who registered and who weren't able to attend. So, questions. Who's got questions for Abdel and Courtney? Anybody have questions? I'll start off with a question. Oh, okay. Here's one from Raluca. As a nurse and planetary health lead for my organization, I found this entire webinar highly practical and look forward to delving deeper into what was shared. Thank you, Abdel and Courtney. Okay. For my first question, Abdel, you mentioned a smoke readiness plan. And I think this is what we're going to be seeing going forward in perhaps all the different extreme weather or climate related events going forward. Which ones would you suggest are mandatory for everybody to do? You mentioned smoke here. You don't have to be in a forest area to experience smoke. What other readiness plans do you see everybody should be doing?
Well, I mean, heat as well. I mean, heat is another emergency that's happening. And if you find yourself living in coastal city, the rising sea level as well is an issue. Like, I mean, you take a city like San Francisco, there are some houses now who's been flooded more and more because the sea level is rising. So having, for example, if you have a hospital next to the sea, don't put, for example, your main transformer underground. Something, things like that. And so you can't, be prepared for more flooding, even if you're not in a hurricane, but you are close to a sea, and, the sea is expected to rise with the melting of the ice caps.
Sure, thank you. And Courtney, on the issue of the PM 2.5 and its makeup, we understand that there's some knowledge from wildfire smoke, but when infrastructure starts to burn, we have so many other chemicals involved there. What I'm wondering is, should we be considering our purchasing practices to look at what would those materials that we purchase, that we put in our facilities, what would they result in if they burned?
I don't think we have the wildfire smoke literature yet to answer that question, but it makes sense, and there's probably other reasons to do that. When you look at sort of the broader, planetary boundary that talks about how, we essentially have let loose so many untested chemicals into our environment that we've passed the planetary boundary for novel substances just based on that. So I would say probably a common sense rule of thumb would be to use less novel untested substances in all hospital sort of building materials and supplies. And that will probably end up having benefits all through, the extraction, the production, the supply chain, and probably also the end of life, which in this case could end up being via a wildfire if our hospital, knock on wood, should ever be actively damaged. Yeah.
Great, thank you. We have a question from Effie. Have technologies like soft ionization, like needlepoint bipolar ionization or UV, been used in hospitals to remove sub-PM 2.5 particles? Any, I guess.
I can answer that, and probably in 7 minutes. I mean, we have 7 minutes. I could probably talk about this for like an hour. I mean, the short answer is yes. I mean, they could be used. The challenge is that it's still a contentious technology, and the reason why is because of the ozone generation. So any needlepoint ionization will generate ozones, and so some of them actually require. There is the UL test now. You can test some of those technology to make sure that they don't generate ozone. And again, there is big debate. What's the safe ozone level indoor? Is it 5 parts per billion or less? And what if you have multiple filter creating all this ozone? That's one. Number two is the ions. And for these to be effective, I mean, if you are considering full flood ions, so basically you generate ions and you flood your space with them, is that there are some studies that showed that you need to get because when they test these technologies, they test them in a shoebox, and they get the concentration to 20,000, 30,000 ion per meter cube, which is almost as much as the high atmosphere. And the question is always, is it safe for buildings, for humans? And some studies have shown no's. Some people have refuted this. This is why it comes back to how contentious the subject is. I'm going to stop here. Otherwise, I'm going to take the entire hour.
Thank you. Okay, a question from Raluca. I was wondering what your thoughts are around building an emergency department response plan that is ready to deploy when AQHI levels increase. What are the best ways to do some rapid capacity building for ED staff when it comes to responding to dangerous AQHI levels? Either of you?
So thanks for the question, Raluca. And Raluca's been involved in this for a while. So I know she knows that the curriculum surveys show that most people haven't been taught about this. So about 2 years ago, I was at the BC Quality Forum audience of about 1,000 people. and asked people to put up their hand if they'd ever had a lecture on air pollution, and only about 15% of the hands went up. And I've done similar things with other audiences. So really, we're at this place where unfortunately many senior leaders don't know what they don't know. I did a landscape analysis and gap analysis that many of you contributed to. Thank you for Health Canada through the Association of Faculties of Medicine of Canada this year. And the #1 gap that the planetary health leaders identified was that the people in charge have not been briefed. And that's a power problem. It's a hierarchy problem. And it makes it really difficult for the people who are in charge of this work to get enough social capital, political capital, financial capital to get on the agenda, to have this prioritized in terms of people's time and in terms of other type of resource dispensation. And so really, I think the answer to this is to get in front of the most powerful person you can by any means possible. So sometimes that might be using your current relationships to have a more powerful person than you help you get the meeting, whatever it is, to say, look, I need time at rounds to brief the clinical staff. We need time at different people's meetings to brief the facility staff. It's really getting on the agenda that is the tough bit, because the material is available. I will give you my slides. I'm sure Abdul has offered to share his. And so really it's a matter of accessing power and then using that access to diffuse the information.
Thank you. Abdel, do you have any comments on that one?
No, not really. I think Courtney covered it well.
Okay. I do have another question, Abdel. You mentioned that if there are critically vulnerable people in the hospital, that they get priority. I'm thinking also now about long-term care facilities and the chronic diseases that come in most of those patients. What would you suggest in terms of an approach at a long-term care facility?
Yeah, I mean, that's a very good question. So these are also people who are really at high risk of wildfire smoke and especially lung diseases. So, and again, comes back to all the thing. I mean, the measures that I mentioned. It kind of depends on the system they have. But again, keeping the building, I mean, you have to keep them out of smoke. So you can keep the building positive. You can add the filtration. But sometimes those long terms are designed like a residential building. So sometimes you can't get high filtration. So you need to, go to portable air cleaners, to deploy portable air cleaners, to reduce PM 2.5 for them. And more importantly, keep the room positive. Don't leave, for example, if you have, don't leave your toilet fan on. It's okay in a wildfire smoke to smell the toilet a little bit. So I mean, because I mean, the toilet fan in your house is making your house negative. So it's basically sucking air from somewhere. So try not to turn the toilet fan, or if you want, turn it very quickly. But once you turn it, your house or your residence will become negative.
Yeah. Thank you. Okay. Any other questions for our speakers? We have 1 minute left. I must say, this has been just a terrific set of presentations, and will be hugely invaluable for all our facility staff going forward. And I thank you so much for the ability to share your presentations in PDF, as well as a copy of this presentation, which we recorded. There were many people that registered for this that were not able to attend, and we will make sure that everybody gets access to these.
Just a quick note, we have Sarah Henderson, myself, some disaster medicine folks and mental health folks have a paper coming out in a couple of weeks in the Lancet Planetary Health that summarizes not the great technical info that Abdel just gave us, but a lot of other info with some really pretty pictures. And so keep an eye out from that. Hopefully it'll help you make the case at your institution.
And that's so important. Yeah, we've got to learn to make the case on so many things now, but this is all helping. So thank you again so much. And thanks for everybody for attending, and wish you all a great rest of your day and stay safe and cool, and don't breathe the smoke in.
Thank you.
Thanks again.
Everybody, thanks Abdel a lot.
Bye-bye.
Thank you.
Bye-bye.